what we do is we try to look at this the other way around. Professor Asaf showed you what do you do and how do you use this report after the problem occurred. We try to prevent it. So the key points here is that the dry eye report in the CSO software is an easy to use, easy to validate, and easy to show to your patient report that you can generate on the spot. You can never underestimate the quality of you giving something to your patient before surgery. And my entire way of thinking about anything has changed. For keratoconus patients, I guess you probably always print out their pentacam and you tell them, take it with you. Now I do not just that, I print off the ocular simulation of their vision. And I do the same with dry eye patients. Why? First of all, because there's so many of them. I don't even think these numbers here are semi-accurate. I think they're triple what it says here. I think there's over 1.5 billion people suffering from dry eye. Why? Because of the way we live. And I tell them all a very sad and funny story. I tell them it's not politically correct, but I tell them it's the fault of people from Africa. And they laugh at me. What do you mean? I say, look, 200, 300,000 years ago, there was one lion and two people. One person had a gene not to blink when he's excited, and the other person kept blinking all the time. And one lion starts hunting both of them, and the one who's blinking, he doesn't see a piece of stone, he trips, he dies, and the lion eats him. So we have this fight or flight mechanism built into our genetic code. So every time we're focused on something, running away from a lion, we don't blink. The problem is our brain and adrenal glands, they're not built for excel. They're built to escape the lion. So from the point of our brain, when we are focusing on excel or on phoenix, we forget to blink. So dry eye disease as such is basically caused by evolution not building us to be relaxed in front of the screen. So we don't blink. That's one of the horrible problems we have. And then when you add menopause or any other hormonal issues, it's just horrible. Out of 10 people I see a week, 6 of them have signs of dry eye. It's insane. So now what we do routinely, we actually routinely do dry eye assessment on every single patient. I don't care why you're in my office. If you want any sort of surgery from me, I'm going to do a dry eye assessment. Now, what do? I talk about symptoms. I don't ask them the OSDI questions. I ask them different questions. Do you ever feel stinging? Do you have to rub your eyes? At the end of the day, is it difficult for you? Is your image quality bad or good during the day or night, whatever? I look at the tear film stability. Every person gets a regular non-invasive tear breakup time on the CSO devices. It's available on Antares, on Moody, on MS39, on Sirius, and on Osiris T. So amazing. Then I don't look at the tear osmolarity. It has very low, it's not easy to do, and it's low predictability in most cases. And then when we used to have Sirius as one of our primary devices, we would routinely do meibography. Now we have to do it on other devices because somebody excluded it from the software, but hey, they might fix it. But we do the report. Now, as far as what's wrong with most of the patients, they have the deficiency. That's the biggest source of problems. So you tell them, you warn them, and then you choose accordingly. And there is very little agreement on what you have to do. So whatever you're doing is better than nothing. It's just a matter of talking to your patient before surgery and before doing anything bad to them, so they know that there is something wrong with them. Because if you don't tell them, hey, listen, Professor Asaf, we can go for surgery, but I have to warn you, you have very poor tear film. There might be some issues after surgery. If you tell that thing, the decision to have surgery is now a shared decision between you as the clinician and the patient. But if you see or think, this patient might have dry eye, but you don't warn them because you're afraid if you warn them, they might not proceed with surgery, so you won't get your fee, and they end up having severe dry eye, very poor quality of vision, then you're doing a disservice to the patient and yourself. Using tools like this is not to discourage you from doing more surgery. It's to share the responsibility between you and your patient. Now, as I said, this can be done with basically any CSO device. They actually used to have a little one that could you mount on a slit lamp. Do you even sell that one anymore? Okay. Now, what goes into the report? You have the OSDI questionnaire. You have the non-invasive tear breakup. You can write in the osmolarity if you want. Redness, you grade. It even pulls up a little scale so you can select, because most people don't know what the scale is supposed to look like. And then you can evaluate the meibography if you have Antares or Sirius or MS-39 soon. This is, can we play the video? This is what I like to actually show my patients. I turn on the damage stream. Simona? Yeah, okay, here it is. This one's of the video. So I turn on Phoenix on my computer, and I turn this on for the patient who has a problem. And I show them, see this? See how your tear film is breaking? See what is causing problems? And then we make a decision together. Hey, based on your bad tear film, do you think that you would be willing to first undergo treatment for dry eye? Or do you think that you would rather have the surgery now and then deal with this problem later? But it's a shared decision. This also influences me for keratofractive surgery, because if I see a patient with any sort of dry eye, both PRK and LASIK are off the table for that person. Because after PRK, they have transitory dry eye. After LASIK, they have transitory dry eye. Lenticle extraction is the only proven way of doing keratofractive surgery with minimal to no effect to their baseline dry eye after 12 weeks. Bulbar redness, evaluated. Tear meniscus, I almost never measure it. I know I'm a bad person for not doing it, but I do the damage stream, I do the redness assessment, and I talk to the patient. It's more than enough for 95% of patients, and then I assess the tear film at the slit lamp, and I just kind of figure out how much millimeters that is. And here's the meibography. This tool is amazing, especially if we have, and I see Professor Asaf as well, you have access to a LipiFlow machine. Access to a LipiFlow machine has been vital, especially in the age group of 50 plus, where patients request any sort of high performance, full range IOLs. Having LipiFlow as a way to save your ass before surgery or after surgery is amazing. Why? Because most of these patients suffer from very poor lipid layer. And if you don't have a way to improve the lipid layer, you're just increasing the amount of aqueous and you're not helping them. And in conclusion, the data assessment should be quick. It should be simple, and it should be done preoperatively for any premium patient. So you can warn them beforehand, and you can show them that they had this problem before you touch them. Thank you.